Do the what?
Just do the Ed Harvey.
Yeah, I'll do the Ed Harvey, okay. Hey, how you doing? No, it's, we're looking here at a tibial model of the leg. The tibia is the most common part of the body that gets compartment syndrome. People talk about the tibia being wrapped by muscle, 4 compartments usually, the anterior, lateral, posterior, and deep posterior. Obviously, there's a lot of concern about being able to monitor all 4 compartments. We've been able to prove in many basic science studies, as well as the clinical studies, that you only have to monitor 1 compartment. And that compartment that we usually monitor is the anterior compartment, which is up front. You can see this device has been sort of placed in the anterior compartment. We do not monitor the posterior compartment uniquely. We monitor the anterior compartment for a number of reasons. One of the reasons is the posterior compartment will tolerate hypoxia much better than the anterior compartment. And actually the anterior compartment is the first muscles to die. So we'd like to monitor that, make sure they don't die. We also have studied the 4 compartments and shown that if you put a device in all 4 compartments, the anterior compartment will show pressure rises even in the posterior. So because of that reason, we've gone to using only 1 monitor. And we have 3,200 cases with only 1 monitor in, with 1 compartment. And that seems to do just fine. We haven't missed any cases, and we haven't done any unnecessary fasciotomies with that approach. So that's important, I think, for all the surgeons out there who are worried about multiple compartments. So you can see that on this leg, we have typically a device in the anterior compartment. You just put the sensor tip in the muscle belly. You don't worry about where the fracture is. You put it right in the biggest part of the muscle. If you move it too far distally, trying to avoid the fracture area, which people used to do with old techniques, then you'll end up in tendon, and tendon will give you false high readings, which is not what you want. The readings can be as high as 100 to 400, depending on how much tendon you're in. And that is not a true reflection of what the pressure is in the compartment. So always put the sensor in the biggest part of the muscle belly you can. Today I can show you the device itself. We have a device here. It's a demo device. It's a 2-piece device that comes assembled as one sterilely. The insertion technique is very easy. You just figure out how to turn it on, which is this button right here. You hold the button down until the logo comes on, you leave it, and it will self-zero. So there we are. It's zeroed. There's no fluid to inject, there's no worries. And once it's zeroed, you can insert it in the leg. It's very easy to insert. You can insert it at any angle. You just have to make sure that it's deep enough in the leg to get through the fat, through the fascia, and into the muscle belly. So if you want to insert this in the muscle belly, you can see here, I'm going to put it in the anterior compartment. There's gratings on here to show where how far down it is. We've got 3 centimeters in. It's in the muscle belly. We wanted to have it in. You see the pressure started to go up with the insertion. You can disengage this device from the trocar. There's a sticky piece that holds the sensor in place. And then to disengage, you rotate it so that it disengages from the sensor and just pull it out. You can then put this device wherever you want on the leg to allow you to read it easily. You can see the pressure is now down to 5, which is more normal pressure in the leg. You wrap it, put a tegaderm on it. You have to make sure you don't put it over the 2 holes here. Those are holes that allow the sensors to equilibrate on their own. And then you measure it. So it measures automatically. And you get a trend over time, which allows you to see what pressure's in the leg and whether, if it's going up, the patients are getting ACS. If it's going down, they're getting better.